Good evening, everyone, or good afternoon, wherever you are. Thanks so much for joining us tonight for Ask Me, our educational webinar series. My name is Audra Hines, Vice President of Care and Advocacy for the ALS Network. I want to thank our lead accessibility and inclusivity sponsor, Mitsubishi Tanabe Pharma America, and our mission benefactor families, as well as everyone who helps support our programming. The contributions from these individuals and families are absolutely amazing, and programs like this one tonight, as well as the multitude of services we provide, wouldn't be possible without these generous donations. We're excited to bring you this important annual educational program for the ALS community as a follow-up to the 15th annual ALS Network Research Summit. The ALS Network's proud to serve as the founding sponsor of the Research Summit since its inception, and we're so grateful to collaborate with some of the country's leading ALS scientists and clinicians like the one we have here tonight. Presenting the latest and greatest updates in the field of ALS research will be the chair of the ALS Network Scientific Advisory Committee, Dr. Clive Svensson, who's the executive director of the Cedars-Sinai Regenerative Medicine Institute, and we'll be joined a little later tonight by Dr. Catherine Lomenherth, clinic director of the ALS Treatment and Research Center at UCSF Medical Center. They're going to update us on the latest and greatest in ALS research. And Clive, I'm going to let you take it away. Thanks so much for being here.
Okay, thank you, Audrey. Can you hear me okay? I'm assuming everybody can hear, so that's great.
That's great.
Okay, good. Welcome, everyone. Lovely to be here for the 15th. Wow, 15 years we've been hosting this research summit, really aimed at bringing together clinicians, scientists, researchers, and everyone really interested in ALS and how we can move forward, and particularly the clinicians. And you hear from Catherine later on about the clinical aspects of the things that we talked about at the meeting. I'm just going to start by talking about the summit, where it originated. This is actually Justin Achida, this year's summit in the front there, having a discussion. It's really a discussion-based meeting. We all get together, we talk, we discuss how can we move things forward faster, what are the synergies between the researchers and the clinicians, and in particularly industry, companies that are developing new drugs. How can we work together to move the field forward? And it's really all about research, networking. As one of our founders, Jim Barber, said, networking is the way to move forward for ALS. So I have the next slide. This year we had 200 attendees, and we we could have more. We had to cap it. We only had that space in the room. There are a lot of people interested. We're discussing whether we should open it up even more widely. After the 15th one, we're now well known throughout the ALS community as a meeting that people really would like to go to and will learn a lot from. But we do try and keep it California based. But we now invite people from all over the country. We had 40 guest speakers, which I'll talk about an overview in a moment. Um, and again, it's more of a international meeting now that we host, and we keep it in person now. COVID's done to make sure we get the interactions as well in the coffee breaks and the other times of the meeting when you get to all meet and talk to each other in this unique environment. And the next slide. So I'm going to talk about the outcomes, and there's some lovely slides here of some of the students and the people who participated. And the theme this year was actually, what can we learn from other disorders that are similar to ALS? And I really want to emphasize at this point, how important it is to look beyond your current area. And this is the same in most science. And I think the theme of looking outwards was very important. And I'm going to make a few comments as well about the importance of the ALS network to research in general before I start and go through what we learned this year. And I'm sure you're all aware of things that are happening in terms of funding from the NIH, National Institutes of Health. They're incredibly important for research, but foundations are as well. The ALS network allows people, researchers, clinicians to do different type of work, maybe more high risk work, and work that is crucial for moving the field forward and developing new therapies. And this current climate of uncertainty at the NIH has actually made things like the ALS network even more important for us researchers because, as you'll hear this year, they're going to be giving out more grants to the researchers and the scientists to collaborate with the clinicians and the industry folks and you, all the ALS patients, to understand more about how to get therapies. So during this turbulent times, the um, organizations such as the ALS Network are an important stabilizer for everybody. And so right now, more than any, we need the ALS Network desperately. We need volunteers, we need donors, we need to keep contributing to this great science outside of the federal chaos right now. I just want to make a quick comment on that. Outcomes this year, what can we learn from ALS, other diseases? And the most familiar to many of you will be spinal muscular atrophy. So we had some of the world experts in spinal muscular atrophy. And please go look at the schedule for the meeting for all the names of everybody and all the people who attended. I'll mention a few along the way. Particularly, I'd like to thank Aaron Gittler and John Day from Stanford. Stanford were our hosts this year. Every year we have a different host. So we had it in San Francisco. And our hosts were Stanford University and Stanford Medical Center. We had a great discussion about spinal muscular atrophy. And spinal muscular atrophy, some people call junior ALS. It's a kind of ALS that we know what the genetic deficit is that causes it. And there's been a very effective therapy for genetic form of ALS called spinal muscular atrophy. It occurs, as many of you may know, in very early babies. And it used to be called floppy baby syndrome because essentially the babies lose the ability to move any muscle. And in spinal muscular atrophy, there's a specific gene mutation, rather like SOD1 ALS, which we'll get to in a moment, and C9orf ALS. We know the mutations in those cases that cause the ALS. And they knew the mutation in spinal muscular atrophy. And so Novartis developed a gene therapy approach initialized by Brian Caspar from California and has been to many of the meetings and who was actually at our meeting this year. And they developed a gene therapy approach. And in fact, that's now being used by Novartis to successfully treat over 1,500 children with spinal muscular atrophy. And so we all discussed how that is very encouraging for adult ALS, the type of ALS that's caused by genetic problems like SOD1 and C9orf, because we think now we'll probably be able to do it when we know the cause of ALS. And in fact, as you well know, Biogen got approval for their drug to treat SOD1 using an ASO, antisense oligonucleotide, which is a type of product, a type of drug that interacts with the gene that's gone wrong in that type of ALS, that subtype of ALS caused by SOD1. And that's really the end point of my discussion will be how we need to understand the different subtypes of ALS so we can develop drug therapies for these individual subtypes. We know about SOD1, we know about C9orf, we know a number of other rarer genes, but we don't know in sporadic ALS, those almost 90% of cases, 85% of cases, we have to understand more about that. So we learned a lot from spinal muscular atrophy. We're also learning a lot from FTD, or frontotemporal dementia. FTD is a type of FTD can be caused by a mutation in C9orf as well. So if you have a C9orf mutation, you could either get frontotemporal dementia or ALS. And we don't understand why, but we had a long discussion over the similarities, dissimilarities, and how this one mutation may be able to cause two independent diseases that affect the brain or affect the spinal cord or both. And I think had some very exciting discussions from a number of people from around the US. Bill Seeley gave a plenary lecture and a number of other speakers brought that field together. The next bullet. A very important topic this year as well as in other years. And here we have to mention our sponsors. You saw the list earlier. One of our main sponsors was CIRM. This is Californian Institute for Regenerative Medicine. You all voted for this, hopefully, in the last election. It was Proposition 14. And this is about $3 billion to go just for stem cell research in the state of California. And gene therapy research in the state of California, and gene therapy and stem cell clinical trials. And so we discussed a lot of modeling with ALS cells. This is a whole area, disease modeling, where we can now take your cells, reprogram them back in time, and make them into a primitive stem cell, and then make your motor neurons in the petri dish and your cortical neurons in the petri dish, and test them and find out maybe are you a specific subtype of ALS. And this was very exciting, lots of new data. Of course, we discussed our trial that's currently going on at Cedars-Sinai. It's been going on for some time now, supported by CIRM, where we're transplanting cells initially into the spinal cord of patients with ALS, stem cells that secrete a powerful growth factor called GDNF. And we're continuing those studies now with a new set of patients, and it's an open trial. So please contact Cedars-Sinai if you want more information, or me, where we're transplanting cells into the part of the brain that controls hand movement to see if those cells can slow down the loss of the motor neurons that you have in ALS. And so we talked about that trial. We talked about the other CIRM-funded studies, and CIRM were there and gave a presentation on how CIRM wants to help with ALS research and clinical trials in the state of California. So very excited to have CIRM involved and look forward to more work with CIRM. The next slide. So other exciting areas, I'll just go through a few and then I'll be done. A few other exciting areas, and again, please read the schedule if they can send it around at the end of this meeting to all of you so you can see some of these details. A highlight was this circulating cell DNA. This means how can we detect if you have ALS? It often takes quite a while. We're never really sure at the beginning. Well, it turns out you have circulating DNA. When your cells start dying, they release DNA into your bloodstream. And there's some beautiful work showing that perhaps that can be detected in the blood early and very specifically will say whether you have ALS. Now, in addition, you can then use that when you give a drug to see if that DNA disappears. It means probably the drug is working. And this is called a biomarker. Right now, we have neurofilament. We have some others, but this is a new biomarker that could be very important for detecting ALS and for following how patients respond to clinical trials. We had this. There's a story in New York Times recently, and a big paper in the New England Journal of Medicine, one of the biggest journals for clinicians in the world. And they reported that a patient with ALS was able to use brain-machine interface to speak. What this means is they attach to this patient electrodes to the brain. The patient thinks about what he wants to say. In this case, a he. It was one person that they demonstrated this could work for. And as he thinks, AI converts his brain waves into a voice synthesizer that then projects out on a speaker. This is quite remarkable technology. It's come a long way in the last 20 years, and it's now getting to the point with people, units in Brown University, in the UC system, California, both Davis and in San Francisco, UCSF. Many groups are studying this, and we had a wonderful talk to discuss how this might help patients with ALS speak. The remarkable thing here was the person had recorded his own voice before he lost his voice, and so the synthesizer was sounding even like the person who was talking before he lost his voice. Remarkable, remarkable technology, and AI is coming. And the next one, please. We were lucky to have Merit Shakovich come and visit on this one. She was one of our plenary speakers, and together with a very powerful group of clinicians, including Catherine, we had an open discussion. Catherine might talk about this, about clinical trials in ALS. It's very disappointing. There's been hundreds of trials, and really we still only have the mainstay of riluzole and edaravone more recently as mainstay drugs for ALS. Of course, we have these newer ones like Biogen for specific subtypes of ALS, but for general ALS, we only still have a couple of drugs that are only mildly effective. We have to change that. And we had a long discussion how we might do that, how the clinicians might work to redesign their trials to make them more effective and faster so we can put drugs through. As you all know, the platform trial at MGH is doing this. They're doing a faster enrollment, doing different types of drugs simultaneously using one patient group as a control, and Merit talked about that. But there are lots of different angles that we need to progress on, and maybe we could look at combining drugs perhaps to try and get more powerful effects. So we had a good discussion. We have 2 sessions on just industry and clinical trial updates. That is new programs, new industry programs that have been running. and new companies that are getting into the field. And we kind of guide them and help them along the way, and then they meet and talk to people. And the next one. And then finally, we ended up with an incredible, this is the last little piece, a little snippet from the meeting, of how we can make new models of ALS using organoid technology. That sounds like a strange thing, but essentially what you do is you take these stem cells I mentioned earlier, they're called induced pluripotent stem cells, and we can make them from any one of you, any ALS patient, we can make the iPS cells from. If you want to go learn about this, actually, you should go visit answerals, one word.org, answerals.org, because my group, together with many collaborators, made 1,000 IPS lines from ALS patients all across the world. Now we're using those ALS lines now, these IPS cells, to develop new models. And the last session was from 5 people who've received funding to make special models of ALS. So they're building organoids from these IPS cells that are patient specific. So we could make your organoids. And very briefly, what we can do is make a cortical organoid. So we make cells that look like the motor cortex. We can make a spinal cord organoid that look like the spinal cord. And then we can make a muscle organoid that looks like the muscle. And what's remarkable is you can stick all these together, what's called an assembloid, and now you can stimulate the motor cortex organoid, and you see the muscle twitch. And this is a remarkable, again, I think this whole meeting was all about technology and how we're bringing technology to ALS. And using those models, we may well be able to understand better what causes ALS and how we can solve the mystery. Next slide. And then finally, we had this wonderful lecture from a Nobel laureate from Stanford, Tom Sudoff, who just talked about Alzheimer's and really how we can learn from the development of drugs for Alzheimer's. The most recent one was an antibody drug, and how we can learn from that and synaptic plasticity, which is how the brain becomes more plastic in the motor neurons, to try and enhance drug development and enhance our treatment of ALS. Next slide. Thank you, Tom. So the outcomes, I think I've mentioned all the way through. There isn't just one type of ALS. I'm not even sure we should call it just ALS anymore. There's SOD1 ALS, there's C9orf ALS. We have new data, hopefully coming out very soon, showing that there's young onset ALS. If you get it very young, it may be a different type. There's going to be subcategories of ALS. Once we understand those, we can develop drugs against each subtype, rather than trying to enroll patients in these very broad trials. Once you know what causes it, you know the subtype, then we can actually develop drugs. And the biomarker I mentioned is important because each subtype may have a slightly different biomarker in the blood. And we can use those biomarkers as we discover them to do clinical trials and see if we're reversing some of the effects that you get. Next one. And I think ultimately enrolling large groups of ALS patients, we might be able to enroll very specific groups into clinical trials. Now, this might be frustrating for some patients because you won't get enrolled unless you're in that subtype. But it's like cancer. If you have cancer now, they'll test you for what type of cancer you've got and enroll you into very specific trials, like immunotherapy trials, which are targeting that type of cancer. And the field has moved way forward in cancer to where we are today in ALS. And I really predict that that's going to happen in ALS. And we need to learn about subtypes so that we can start developing drugs to specific types of ALS. And I think stem cell models of disease, the types of disease models that we discussed at the meeting, are one way that we can do this very effectively. And we're very excited about that. And so thank you to all the summit organizers and all the work that went into putting this together. And the next one. So as part of the summit, we have the Barber Awards. These are fantastic. This is where I really enjoy the meeting most, is we have the young presenters, the people who the PhD students, the postdocs who are fresh out of graduate school. I'm very excited to do research in this area. And of course, we honor our great friend Jim Barber, who was one of the founders of this program, of the network, came up with the term, we should create a network. He, of course, had ALS and passed away in 2016, but his wife and family support the meeting still. He's all in our hearts and in our spirits. And we're very excited to announce this year's Barber Awards, which he supports through his generous gift of $1,000 to each of the winners. And this year, we had a winner from UCSD, a winner from USC, and a winner from Cedars-Sinai. So Olatz, Jasper, and Vladimir, we're very excited that you joined us this year. That you it was a competitive poster session. We had, I think, 30 or 40 posters this year. So congratulations to the three of you, and spend the money wisely. So next slide, please. Look, I'm at the end. That was my 20 minutes. I'm so excited to be able to present ALS Network. You did a great job again organizing, Audra and all the team, and we look forward to next year.
Well, we can't thank you enough, Dr. Svensson. We couldn't do this without you by any stretch of the imagination. Appreciate you being here tonight. We're going to ask you some questions later, I know, for certain after Dr. Lumenherth's presentation. So thank you for all this great update. Dr. Catherine Lumenherth, as I mentioned before, she's the ALS Clinic Director from UC San Francisco. Super happy to have both of these extremely knowledgeable experts here with us tonight. So Dr. Lumenherth, I'll let you take it away.
All right, thank you so much. And I would like to acknowledge a question in the chat that I'm going to be getting to during my talk. So I have not answered that one live. But thank you so much for having me and for that wonderful summary, Clive, about the meeting. I'll weave into my talk a little bit about what updates happened at the summit and just reinforce a few of the things that he mentioned. So I'm just going to see if I can share my screen okay, and then I will get started with the slideshow. Okay. Everyone can see that okay, hopefully?
Yeah, it looks great.
Okay, great. Thank you. All right, so I'm going to talk today a little bit about some clinical trial updates as well as symptom management, because what we know about ALS so far is that what we do in caring for patients in the multidisciplinary clinic prolongs both life and actually supports quality of life better than any medications we have to date. And so that's why I wanted to particularly emphasize that, because while we are waiting for those treatments to be developed that Clive mentioned in the lab, we want to make sure that people have the best quality and quantity of life as possible in the meantime. Okay. See, I'm just trying a little, oh, there we go. Okay. So as those of you who know who have ALS, it's unfortunately universally fatal, and mean survival after first symptom is only 3 to 5 years. But it's a very wide range. So I've had patients who have died 2 months after their first symptom, and I've had patients still walking 10 years after their first symptom. So it's very, very, very variable. It is the most common adult onset motor neuron disease, the most common pediatric one, spinal muscular atrophy, which Clive mentioned earlier, usually starts in childhood. And then the pathology is very complex and incompletely understood. And that's why it makes it so hard for us to treat the condition. But every patient is unique. And that's part of what I'm going to talk about today. So patients can vary in terms of how quickly they're progressing, the regions that are affected. Some people start with difficulty speaking or swallowing. Other people start with weakness in an arm or leg. Sometimes people have a family history of degenerative disease. Sometimes people don't. There can be, but this accurate categorization of patients into clinical trials is really of utmost importance in terms of helping to facilitate the research. And so a lot of effort is being done in terms of thinking how can we better strategize, basically put patients into different groups so that we make sure that we're treating when we do a clinical trial, that the groups are balanced, and that in the treatment group, we have the same type of patients that are in the placebo group. Otherwise, we can miss an effect. And then a key aspect of the disease is this heterogeneity is the cognitive and behavioral overlap, including frontotemporal dementia. And I do see there's a question in the chat talking about research on other neurodegenerative diseases. And as Clive mentioned, there's this one gene, C9orf72, that I won't be talking about today in my talk, that causes both ALS and frontotemporal dementia. And a lot of research is moving forward to think about how to treat both of these diseases. Okay. For some reason, my slides are not advancing so well, but I will see if I can do it. There we go. All right. So there was also a question that Chad about environmental risk factors, a very important question. And that's something that at UCSF, we're doing research, trying to study some of the different places where we have satellite clinics, Fresno, Modesto, Monterey, Santa Rosa, and try to see if there are differences in these regions as far as the environment compared to patients in San Francisco. But what we do know about environmental risk factors is that trauma seems to be associated with degenerative diseases, not just ALS, but Alzheimer's disease, frontotemporal dementia, Parkinsonism, and there's a particular pathology that that is found as well, and then also with sorry, my slides aren't advancing. There's an increased frequency of degenerative disease and trauma-causing professions, things like people who play soccer, NFL players, and importantly, military veterans are twice as likely to get ALS. It is more common in those that are deployed versus those that are not deployed, but an important point in the Q&A that was mentioned is that for those who were on bases, they definitely had a lot of risks as well in terms of toxic exposures. Okay, so next I want to just turn to the clinical features of ALS and how we treat some of these various symptoms. So those of you who have ALS are aware that it can affect all parts of the motor system. It can cause difficulty with speaking, brisk reflexes, stiffness. Those types of symptoms are more upper motor neurons, and the figure shows the dashed lines, which show the upper motor neurons. And then the solid lines that are coming out from the spinal cord and the brain are the lower motor neurons, and damage to those types of nerves tend to cause atrophy, fasciculations, and weakness. And so one thing that's very important whenever a diagnosis of ALS is considered is to make sure that everything else has been ruled out, because we don't currently have a blood test to say that, yes, you have this positive blood test, therefore you have ALS. A lot of people are working on that, trying to find biomarkers that would be specific for ALS, but for right now, we don't have that test. And so it's important for people who have a diagnosis of possible ALS to have imaging done, to look for other types of structural things that could cause the symptoms, to look for certain neuropathies, endocrine problems, lead toxicity, and infections such as Lyme disease or HIV. So how do we treat it? The challenge, as Clive already mentioned, is that there are so many things that are defective in ALS that it's sometimes hard to know where to start. And researchers are targeting all of these different aspects of the dying nerve to try to see if we can make a difference in the condition. And so currently there are 4 FDA-approved drugs for ALS, and I'll just talk about them briefly. We have riluzole, which is a glutamate antagonist, so it helps to absorb this toxic chemical. And then Nudexta is an NMDA antagonist, and this was FDA approved back in 2011 for easy laughing and crying, which can be a common symptom in ALS. But anecdotally, it has been shown to sometimes help with speaking and swallowing. So it's something that we will often prescribe for our patients who have easy laughing and crying and or have difficulty with speaking and swallowing, to see if that might be effective. And then edaravone, radicava, many of you know of that term in the US, is a free radical scavenger, and that was FDA approved in 2017 to treat ALS. First, it was released in an intravenous form, and now it's available in an oral form. And then the most recent approval was with tofersen, which is an antisense oligonucleotide. And this was FDA approved in 2023 to treat a very particular form of ALS called SOD1 ALS. And there was a question in the chat about if you have sporadic disease and don't have a family history, is it still a good idea to be tested for genetic forms of ALS? And it absolutely is, because sometimes people can have a genetic mutation and not have a family history. And so while SOD1 ALS is only 1% of all ALS, because we have this new treatment that's very specific, what we do at our clinic, and I think most clinics, is to test all of our ALS patients, regardless of whether people have a family history or not, for genes that cause ALS. And that testing is free. There are various companies that will do it for free. We happen to use Invitae Diagnostics. They send a kit to your home, you swab your cheek, and you send it back. You can even sign up to get the click kit online yourself directly from the company, or it can be ordered from whatever clinic you're attending. But that's important, definitely important to do that. And then this just shows the benefit of riluzole on survival. In green is the effect of riluzole, and then in white is the placebo group. And you can see that the riluzole group, treated group, lived approximately 3 months longer than those patients who did not take riluzole. And then edaravone, this is a free radical scavenger, and it was initially not shown to be effective in treating ALS in Japan. And then a subgroup analysis showed a benefit of slowing in people who were earlier in their disease process. And that was confirmed by a larger study in Japanese patients, which led to the FDA approval. In the meantime, Europe was doing a study with edaravone, a slightly different formulation, taken every day as opposed to 10 days out of each month. And that study was negative. And so one thing that was helpful is at the summit, the MT Pharma presented some data showing long-term edaravone use, because now it's been released for several years, taking it on this intermittent basis, the 10 days on and then the rest of the month off, that it did show benefit in a post-hoc analysis at slowing the disease process. So we are still recommending that our patients with ALS take Radicava. And this just shows the separation of the groups. The blue is the placebo group and red is the edaravone group. And you can see that there is a slowing based on the ALS functional rating scale. Many of you have that done in your clinic visit, which basically tracks how you are progressing over time as far as your speech, your arm strength, your leg strength, and your breathing. And what we're looking for is in the placebo group, that score is declining at a rate that is faster than in the edaravone treated group. And so it was this data that led to the approval of this drug by the FDA in 2017. And then just a little more about tofersen, I mentioned, is an antisense oligonucleotide therapy. It showed that in just 8 weeks, the levels of protein were reduced by 35%. And then this biomarker, neurofilament light chain, that is being used more and more in clinical trials to look at disease progression, those levels were reduced by 50% with the treatment. And earlier initiation of tofersen was found to work better than taking it later on. And then currently there is the ATLAS trial, which is testing people with the SOD1 mutation who have not yet developed symptoms of ALS, to see if it might be possible to prevent the disease. So that's quite exciting for those people who have this mutation. Sorry, slide seems to have trouble advancing. Okay, so how do you find a clinical trial? I think that the one-stop shop for really all questions ALS is to connect with the ALS network. They have care managers throughout California. They will connect you with a care manager in your local area who can really help you navigate the disease, whether it be connecting you to a certified clinic or helping you to find resources, to find a caregiver, or helping you to be able to connect with research. So I would highly recommend, if you don't have a care manager yet, to connect with the ALS network. And they have wonderful email updates, and they keep their website very up to date. And so that's a really great way to get reliable information about ALS. Clive mentioned the Healy platform trial, and that's the big trial for ALS. It has been for several years, because for several reasons. One is it's a trial that kind of lives on forever. So different drugs are cycled in to be tested, and then once a drug is finished testing, if a patient is in that trial, they can decide, oh, I want to continue to take this drug in open label, or I want to move into a new trial and take a new drug. And as long as they meet the enrollment criteria, they can easily flip into trying a new drug. So it's a wonderful study that really shortens the development of drugs. It reduces the time of a clinical trial from 10 years to 4 years. And so far they have tested 7 different, yeah, I think that's right, 7 different drugs. They finished, they went through G, and so they're currently taking a pause for a few months just to think about the study design, because many of the drugs that were tested were not promising, and making sure they're having patients in the study long enough. So they're having a big meeting in March and are going to be redoing the enrollment criteria. And so that should be up and running in a few months after that. So on hold at the moment, but that's really kind of one of the biggest trials with ALS around the country. It's easy to go to their website to learn more and to find a center that is participating in that trial. There are other smaller trials that various institutions around California are doing, testing other potential new drugs. And those, you really have to just connect to your individual center to be able to learn more about those, or use the MDA Clinical Trial Finder or the NIH Clinical Trial Site. Those are all really great sites to use. And I think, Clive mentioned it briefly, but I really want to put a plug in for his very innovative trial with treating patients with stem cell therapy, surgically implanting the stem cells right where the disease is happening, and looking for benefit. And I was so impressed to learn that those cells are living, 4 years or longer after being implanted. So that's quite an exciting trial at Cedars-Sinai that you can go to their website and learn more about as well. Okay, so I had mentioned that there are many treatable symptoms in ALS, and I'd like to go through that briefly, and then Clive and I can take questions at the end. But really, from top to bottom, there are just so many treatable symptoms that occur in ALS. And so taking these one by one, nutrition is so important in the disease. When you lose weight, you lose muscle. Whether you are ill with ALS or you're a perfectly healthy person, whenever you lose weight quickly, you lose muscle, and that's not good for ALS. And there can be many causes. It can be eating slower because of difficulty swallowing. It can be arm weakness, making it difficult to get food to the mouth, shortness of breath, burns a lot of calories. Just walking around with a weak limb can take much more energy than it used to. Walking across the room for someone with a really weak leg can be the same as someone else running sprints around the block. So your people with ALS are burning more calories, and they're also having more difficulty getting access to food often, and having difficulty with food intake because of swallowing. And so we think about supporting the disease in a variety of ways. One is with making sure that people have good breathing support if they're having shortness of breath. Eating aids, there's an OB feeding device that's really nice, that actually is like a little robot that sits on the counter and has a fork, and will be able to feed someone who's not able to use their arms. Focusing on high calories and high protein is a good idea. Thinking about calorie density in the food that you are eating in order to be able to be efficient with your food, and thinking about modifying food consistency as well. And then ultimately, your doctor may talk with you about a feeding tube, which you can still eat whatever you like, but it helps to be able to give you more the appropriate calories that you need. And so it's really a balance, I think, when thinking about nutrition, comfort, focusing on enjoying food, efficiency, trying to think about how to be able to get the food and water in an efficient way. There are water thickeners that you can buy, thickened water. You can use thicket from the grocery store to thicken the foods that you're eating to make them easier to swallow. And then safety, of course, is important, making sure food is cut up very small to reduce the risk of choking or aspiration. Okay. And then breathing. So many causes of breathing issues. It can be due to diaphragm weakness, chest muscle weakness, as well as increased energy expenditure can make someone struggle with breathing. And so There are a variety of solutions. Breath stacking and a cough assist machine can be used to help really expand the lungs and make sure that the lungs are being used as efficiently as possible. Non-invasive positive pressure ventilation is really a game changer with the disease, with studies showing it can prolong life by more than a year and really helps with quality of life, being able to get rid of that excess CO2, get the oxygen into the lungs so that people have more energy, sleep better, and feel better. And then diaphragm stimulation is something that was tried and theoretically can work well in someone who has a diaphragm weakness from other causes, such as a spinal cord injury. But for ALS, it turned out to not be as effective. But I keep it on the side because many people have heard about diaphragm stimulation and still ask me about it. And so this is just summarizing all the things that breathing equipment can help with: daytime fatigue, shortness of breath, cognition, morning headaches, and also can help with speech, because if you have better breath support, then your speech is better as well. Cramps are a huge problem with the disease and can often be treated conservatively with things like massage, a hot bath, stretching. Tegretol and baclofen are good medications that can help with cramps, as well as mixilotine. And then quinine sulfate is still available in Canada, and that is quite effective for cramps. Tonic water does contain low amounts of quinine, but may not be in a high enough concentration to fully take care of cramps. Spasticity is due to that upper motor neuron damage that I mentioned earlier in the talk, and it's really a balance between being too stiff and too loose. So if you take medication that relaxes the muscles too much, then your legs might be like wet noodles and it's very hard to walk around. Too little, and you may have difficulty moving because of the stiffness. So you want to take just the right amount of medication so that you're not feeling too uncomfortable from the stiffness, but not too loose that it's impacting your ability to move around. Baclofen is really, I think, the most effective drug for spasticity, but people can also take benzodiazepines, dantrolene, memantine, and tizanidine are other drugs that are sometimes used if people are not getting a response for baclofen. And then we often will consider a baclofen pump. That's a procedure that is done at UCSF and other institutions where a pump is put in. It kind of looks like a pacemaker under the skin. And then a tube goes right into the spinal fluid and releases baclofen at low amounts so that you can have a more consistent amount of baclofen without that side effect of sleepiness. So that's a really a good option for someone who maybe is having trouble tolerating baclofen. And then Botox for focal spasticity is another really wonderful technique to try to help relieve that stiffness if there's just particular muscles that are really tight and uncomfortable. And then excess saliva can be a big problem. It's not that the body's producing too much saliva, it's just that as swallowing slows down, you slow down the rate that you're swallowing saliva and it can really accumulate. And so we use a variety of drying medications that can help. There are pills, drops, patches. Sometimes patients will have radiation therapy to help with managing saliva. And then Botox is very common, where every 3 months you can have Botox to your parotid and submandibular salivary glands, and that helps to decrease the production of the saliva, which really helps with managing that. One thing problem when you dry up saliva is that it gets thick, and you can also have problems with constipation. And so a few options are to take things like Robitussin, guaifenesin, Mucinex. Those are just different brand names for guaifenesin. Papaya enzyme and pineapple are often effective. Increasing fluids helps. Hypertonic saline and also mucibus nebulizer, and the N-acetylcysteine, which is the component of mucimist, you can now get over the counter too. It's actually at Costco, and you can take, it's called NAC, and you can take 1 tablet twice a day, and that will also help to thin that saliva. And then cough assist machine and suction machine can help as well. But keep in mind that any of these drying medications are going to cause constipation, and so it's important to keep up on that. And I'll get to ways to treat constipation coming up. I mentioned about suitable bore affect or easy laughing and crying, and we often do a CNS-LS scale in our clinic to be able to determine if people have these symptoms. And the new Dexa is very effective at treating it. The other antidepressants can sometimes have a more mild effect on the symptoms. And what's nice is it can be available affordably from a compounding pharmacy if there are insurance issues covering new Dexa. So be sure to not pay out of pocket if that's really true of any of these medications. ALS medications, companies often have nonprofit agencies that help with coverage of copays if people have high copays. So I would really encourage you, if you go to pick up a medication or have a medication delivered to you and the copay seems particularly high, definitely talk to the clinic that you're attending and ask them for help to connect you with resources so you don't have to pay a high copay. And this is just the scale that you can find online, just asking people questions about their laughing and their crying. And this just shows how well it works. You can see that in the percentage of group that were in remission after just 14 days was quite good with not having problems with that symptom. Urinary urgency can be a problem and can really disrupt sleep if you're finding yourself feeling like you have to go to the bathroom more frequently than before. There are medications that can help with that. There's condom catheters you can wear at night. There's different catheters. There's a PureWick catheter that's like a suction machine that can be very helpful for women in particular. At night to help manage the urine so you don't have to get out of bed. And then people can have surgery to put in a suprapubic catheter. Sometimes that's helpful if someone is bedbound. And then there are male and female urinals as well. So there are ways to treat that symptom, definitely. So it can be good to raise with your doctor. With depression, we always want to make sure to exclude a respiratory problem because depression can really mimic, or respiratory issues can mimic depression. And so we want to make sure their breathing is good and nutrition is good and sleep. Those are three things that can really make someone feel terrible. But when depression is identified, counseling is very helpful, as well as starting an antidepressant is needed. And many clinics, like our clinics, have a connection with a palliative care group, and they're very helpful in terms of helping with coping with the disease. And then as far as sleep, most sleep problems with ALS are mechanical, either lack of breathing support or difficulty positioning during the night for comfort because it's hard to turn. And so making sure that people have appropriate breathing support, keeping the head of the bed elevated at night can help. And then starting treatment, just starting with something mild first, like melatonin can be good. And then consider sedating depressants. I often like trazodone or Remeron. And then the benzodiazepines like Valium can help with sleep and with spasticity. So that's another option as well. And then I mentioned constipation as an important problem to be sure to treat. It's good if you haven't had a bowel movement in, I would say, 48 hours. It's important to think about starting medications to get things moving so that you don't have to have an emergency visit to the ER. It can be quite dangerous if you have constipation. So that's not treated. So we think about increasing fluids, increasing fiber, considering stool softeners. Lactulose is a prescription medication that can be quite good for constipation. And there are now mini enemas, so that are all pre-made, so at the drugstore. So it's much easier also to give an enema than it used to be. There's prune juice is an old-fashioned remedy, and then also Miralax is another thing that can be quite good for constipation. With weakness, it's really important to think about how to optimize functioning. So optimizing home, work environment if the patient is working outside the home still, and then think about anticipating equipment needs before they're absolutely needed. If families are concerned that, or the patient's concerned that they might not be safe driving because of their weakness, It's very easy to go to the DMV and have a driving assessment, and then they can certify that you are or are not safe to be driving. The cost is fairly mild, but that can be an important way to get back to driving. And then, believe it or not, exercise can be helpful. So mild exercise for muscles that are not terribly weak can be really good and have been shown to really help with quality of life as well as quantity of life, doing some exercise. And here's just a little summary of thinking about how to exercise safely. So if you're overworked, you want to adjust your exercise to be a little bit, to give you that emotional benefit as well as some strength benefit, but not so much that you're actually tearing down the muscles and can make the muscles weaker. The AT network in California can come out and do a work assessment and help make recommendations so that your work is safe. And then and you can continue to do your work effectively. And then with home assessments, we can very easily order home safety assessments that can help to determine what equipment would be useful. PT, OT, and SLP can all come into the home and can see patients. And then there are specialty contractors that can help with home remodeling if it looks like your home needs to be remodeling. And then hospice actually also has equipment as well. So if you're at that stage where maybe things are progressing quickly and there's just not time to get a lot of equipment, hospice can provide a hospital bed, wheelchair, commode, things like that. And there have been so many advances in equipment, really every year. Things get lighter and work better. There are walkers that are like 14 pounds and carbon fiber orthotics. So it's easier than ever to obtain equipment, and prices have come down quite a bit with equipment as well. There are manual wheelchairs that can have tilt and recline features. Medicare now does pay with electric wheelchairs for both the seat elevation feature as well as tilt and recline feature. So when a more sturdy wheelchair is needed, that is all covered by insurance. There's stair lifts, stair climbers, portable ramps, rail systems, and there are even specialized beds that can turn patients if it's hard to turn from side to side. So many, many advances in equipment. And as Clive mentioned, the advances in speech and communication technology are really incredible. We have the Bravo trial at UCSF that is an implantable device to try to help patients speak, and a patient of mine is going to be doing that next week. So I'm excited to see how that turns out. I already talked about a lot of the benefits of exercise. It also can help to reduce spasticity and really elevates mood. So trying to safely exercise when you can is important. Communication is also so important, and I think there's many different types of communication, both low tech with a scanning board, mid tech, things like an voice amplifier that you can get on the internet for about $20, and your family can hear you better if you're finding your voice is weak and it's hard for you to project. And then there's high tech devices like eye gaze systems if someone's not able to type or use their hands. So many options for communication. So it's important to connect with a speech language pathologist if you're having bulbar symptoms. I wanted to just say a word about end of life issues. I think that most clinics try to address this throughout the disease process because I think it's important not to be surprised or caught off guard. It's important for everyone to have an advance directive in a POLST form, POLST. That's something you can download online, and it basically just gives you the opportunity to let people in your life or strangers, if someone were to call 911, what your wishes would be if you were to be found on the floor, unresponsive. What would you want people to do? Would you want them to call 911? If they did call 911, how aggressive would you want them to be around their resuscitation? And I think it's really important to think these things through when you're feeling fine in a non-stressful situation, so that your family and friends know exactly what your wishes are, so that they can help to carry those out. I think it's really helpful to enroll in hospice as soon as people are eligible for hospice, and that's typically when the breathing capacity is at 30%. The reason being is that they have a lot of services they can provide. They can bring you all your medications. They pay for your medications. They can help you with equipment. You can usually call a nurse 24/7 if you have questions, and oftentimes they'll have other services like a bath aid that can help. So because hospice does have a lot of great services, I think it's nice to think about enrolling as soon as you're eligible. And most hospice agencies will allow you to continue riluzole since it is a generic medication, but typically if you want to take Radicava, usually you cannot do that if you are in hospice. So that's the one downside of starting hospice when you're eligible. But home care can also be utilized if you're not hospice eligible. I mentioned that physical therapy, occupational therapy, and speech, those agencies can all come into the home and can work with you to help try to optimize your functioning, thinking about what equipment would be helpful for you. And then it's really the other thing that's nice is you can continue to follow with an ALS multidisciplinary clinic even while you're in hospice, coming to clinic in person or on video. And what's nice too about some of the laws that were relaxed during COVID is that we can actually see patients even if they're in a nursing home or in a skilled care facility. So if someone's been in the hospital and they're not quite ready to go home, we can even do video visits in a facility. So I think the ALS multidisciplinary clinic is just so important in terms of thinking about helping you throughout the entire process. So what I've tried to share today is that we have medications to treat many of the symptoms of ALS. Equipment advances can enable patients to be more independent than ever, and more advances happening every day. And then multidisciplinary clinics do improve quality of life for patients as well as impact survival by over a year. And typically in a multidisciplinary clinic, these will be some of the people who will be present, a neurologist, a nurse, a speech pathologist, dietitian, respiratory therapist, physical therapist, occupational therapist, social worker, rehabilitation, a technologist. And there are often clinics will consult with a rehab physician, a pulmonologist, a gastroenterologist, and then we certainly have strong connections with research scientists, with the ALS Network, the ALS Association, and Muscular Dystrophy Association, all organizations that help to support our clinics. And this is just our clinic, UCSF, doing the Ice Bucket Challenge many years ago. So thank you very much, and I look forward to the questions.
Thank you, Dr. Lomenhert. Thanks to both you and Dr. Svensson. Really great information. I'm going to ask some of these questions out loud, just in case some of others of you in the audience may have similar questions. Dr. Lomenhert, you might have answered this just a little bit earlier, but I just want to go back. Someone's asking, is there any research involving the interstitium and its connection to neurodegenerative diseases that could be applied to ALS?
I did not answer that. I don't know if Clive has a...
Maybe that's Dr. Svensson.
I don't know. I have no clue on that one. Sorry. I don't even know quite what you mean by the interstitium, but maybe you could clarify. If whoever asks a question maybe wants to clarify a bit more, that would be great.
Okay, yeah, that's perfect. Next question, are there ongoing efforts to include SPTLC2 mutations in broader ALS research? This is for pediatric ALS, and how do we ensure that young people with ALS are included in clinical trials and research?
Yeah, I think, my understanding from the various, ALS meetings I've been to is that really every known genetic mutation that can cause ALS, a lot of active research is being done. I'm not aware of a drug imminently available for testing, but I think it's an important point, and researchers are working very hard with all known genes that can cause ALS.
I'll just add to that. There's a group at Columbia that are working on, and there's something called NLRM that are working on very rare diseases. And many of the mutations in ALS are quite rare. I mean, there's over 50 or 60 mutations, and some only affect literally a handful of ALS patients, right, Catherine? So maybe 20 patients for some. And there's good examples of where they're now developing drugs specifically, mainly antisense oligonucleotides, which are these drugs which bind to the problem area of the genome. and block the toxic effects of whatever it's producing that cause ALS. And there's one genetic form of ALS caused by FUS, which is a mutation in a certain type of protein in the cell. And there've been very exciting results coming out of Colombia and elsewhere where they're just targeting this small population. So for SPL and any mutation, I think, like I said, if you know what's causing and driving the disease, we really have a chance to target it with modern molecular therapies, CRISPR editing, and antisense oligos. So these are all long words, but essentially we're saying, well, we know SOD1 causes a disease, so why not block it? Because in SOD1, it's just making too much bad protein, and that's what Biogen have done with their trial. So we've got to discover more of those, and discovery comes through research. And I think that's where, and Catherine mentioned, donating your cheek sample or your saliva to get DNA analysis is really important because there are probably other forms of ALS, genetic forms, that we still haven't discovered yet. It might be that everybody has a certain genetic problem that causes their ALS. And with big data now and AI, we're getting closer, to be frank, to understand how that works. So look out. There's some very exciting, and I think we're getting closer now to getting these subtypes, and that's where we should be focusing, I think, a lot of energy in the field with the clinicians and the researchers.
Thank you both for that. Another question, is it common for a diagnosis of peripheral neuropathy to be made instead of ALS in an attempt to avoid the worst diagnosis?
Yeah, thank you for that question. I personally have not seen that. What I have seen is definitely, I think, a lot of searching for more common types of diseases besides ALS, and just making sure a lot of times people might initially think that someone with ALS symptoms, they've had a stroke, or maybe they might initially think, could this be a neuropathy? Could this be a myasthenia gravis? Things like that. But as the diagnosis process progresses, as patients have EMG studies done to look more precisely at the cause, I feel like if people think the diagnosis is ALS, then they will usually tell patients it's ALS, or if they're not sure, refer them to a center. So I'm sorry if there was a misdiagnosis of peripheral neuropathy. I haven't seen that particular misdiagnosis yet.
Thanks for that. A couple of questions about the gut microbiome and how that plays a role in ALS, and if it causes neuroinflammation, if you have any.
Yeah, thank you. Yeah, we presented a poster from our group at the summit. That's something we're actively researching. So there have been papers published that show that there are differences in the gut between patients with ALS and controls. And so we're trying to understand a little more precisely what might be going on with that, and what are some of the differences. Maybe we could find some biomarkers that might indicate, particular microbes that are more important or at causing the disease or slowing things down. But it's not just with ALS or with neurology in general. Really, with many diseases, there's been a focus on the gut microbiome, understanding that the particular bacteria that are in our gut and the way they're processing toxins that we're taking in, medications we're taking in, can impact the disease. So we don't have answers for you yet, but hope to in the near future. We're, as I was mentioning, we're looking at some of the different areas in California and comparing that to San Francisco and trying to see if there are differences.
Probably this one's for you, Dr. Lemonherth. Any suggestions for neuropathy at night, burning ankles or burning heels?
Yeah, so I think typically most patients with ALS do not have neuropathy type symptoms, but many times people can have ALS and a neuropathy. And so there are good medications, particularly Neurontin is a very good one to try to help treat it. But it's very important to be evaluated by a doctor, because if you there's treatable causes, for example, like diabetes or alcohol can be toxic to nerves. So sometimes there are things that can be done to actually reverse some of those neuropathy symptoms. So it's good to be evaluated by a doctor, and then we do have good treatments for that type of nerve pain.
That's great, thanks. What about clinical trials that are specific to PLS? Anything happening with that?
Well, there was a big effort by Hiroshi Mishimoto in Colombia to put together around the country as many patients as with PLS as possible for a registry and track them over time to look to see how many of those people may progress into ALS, what is the natural history of that disease, and then that registry will be used to solicit patients for clinical trials as soon as we are ready to do a clinical trial of a drug in patients with PLS. But for right now, that is not yeah, there's not a drug at this moment that's being tested.
I'll just add to that at Cedars-Sinai, Frank Diaz, we're doing a trial there. Just it's a non-invasive, it's not a drug trial, it's just a clinical trial, just looking at the brain in PLS patients and non-PLS, so ALS patients over time, because trying to understand how the brain changes in ALS is very important. So that's something else if you're interested in getting enrolling in a non-drug trial, but something, a lot of the trials we run are learning trials, how we understand what happens in ALS, and they're very important to go. And this would mean sitting in a scanner for 15, 20 minutes and signing an IRB consent form. That's another interesting area. And I think Catherine, Dr. Loneworth was saying, with PLS, it's a fascinating question as to how the brain and the spinal cord work together. And is that a specific type of disease when you have upper motor neuron? And by doing the imaging and these kind of imaging studies, we might learn more about how the brain changes and how the spinal cord changes in the progression of the disease. So I always encourage people to get involved in as many trials as they can, even if they're not a drug trial, because we'll learn so much from these. Anything we can understand and discover about the different forms of ALS will help us with drug therapies in the future.
Thank you so much. That's so helpful from both of you. Is there, maybe for you, Dr. Swenson, is there an active effort to look for new genetic variances associated with ALS?
Massive effort. We're all very, and we struggled and tried. I tell you, so ALS, Alzheimer's, and Parkinson's are three major neurodegenerative diseases. Remarkably, and I never understood this, they about 10 to 15% we can understand because they're caused by specific genetic mutations. It's true for ALS, it's true for Parkinson's, a little less for Alzheimer's. The rest, we just can't get the genetics on to a degree where we can say there's one gene that causes your disease. But what's happening is in those other patients who don't have one gene that causes the disease, like C9orf or SOD1, we're finding now traits, trends. In Alzheimer's, it's ApoE. It's another gene that's altered. And we know now it doesn't say you're definitely going to get ALS, but it significantly enhances your risk of getting ALS. And one of those are UNC gene in ALS and a taxin. So we're discovering now these weaker associations that increase risk. And so I think bringing AI in, we're going to actually understand if you've got a taxin risk and you've got an UNC risk and a weak genome, we may be able to tell you that your chances of getting ALS are much higher. And then we can start thinking about preventive strategies. So we're getting there with genetics, but I think we've exhausted all of the what we call direct hits like SOD1 and I'm not sure there's any left to discover. We've looked really hard. I'll end by saying on this note, there's a new technique for DNA sequencing is evolving. When I started in science, there wasn't DNA sequencing. So there was no genetics. The first genome cost, close to $100 million to sequence every part of the genome. Now we can do it for around $700. I mean, it's remarkable. And now there are these things called repeats in the genome. And in C9, it's not actually caused by a mutation, but it's caused by repeats. So the same sequence going over and over again, sitting, it's like a mess of the genome. It's just messed up. And you can only detect that with a certain type of sequencing. It's called long read sequencing. And we're just starting to do, that's a new technology with nanotechnology, and actually takes each individual part of the DNA and individually puts it together and stitches it into one massive long trail. And you can only do this with modern AI and technology, and then it rebuilds your whole genome for you. And we're just starting to look at that in ALS, and I think we'll discover more repeats, which are another inside the genome, which normally get missed on genome sequencing. And so we're very excited to start those long read studies in genomics. I mean, there's a lot more coming in genetics. I think ultimately, Dr. Lohmann, I don't know what you think. I think it's going to be, 50-50 perhaps genetics and environment in the end. Genetics always say, load the gun and the environment pulls the trigger. So we're all loaded. And if you're in the wrong place at the wrong time, we heard from the army earlier on, or you're a soccer player and you're exposed to head trauma and chemicals in the grass, if you have had a weak phenotype, genotype, your genetics are a little weak, and you're exposed to that combination is probably what triggers it, but we don't understand yet. It's very, very complicated, guys. I wish we knew because we'd be able to fix it.
Yeah, exactly. I tried to answer most of the Q&A questions in the Q&A, but there was one that came through the chat that I wanted to address. It says, what is being done in the way of clinical trials for slow progression? Because this person was diagnosed in July of 2017. And so I think that gives me an opportunity to mention an important initiative that Congress approved, and that is the Act for ALS legislation, which allows patients who do not qualify to be in a clinical trial for whatever reason, because they've had the disease too long or their breathing is too advanced. It allows them to be able to take medications that are in clinical trials, and that it's important for many reasons. Number one is it's important to make sure that people can have equal access to potentially treatments that could significantly impact the disease. And also it's valuable for people who are developing drugs to know how the drug works at different stages of the disease. So it helps everyone. And I think that's quite exciting legislation. And I think now when people do a clinical trial, they work typically to apply for that funding so that they can offer treatments to people who otherwise don't qualify for a clinical trial.
And where can you find that information, Catherine? Where would you go to find that?
So on whatever trial is being advertised on clinicaltrials.gov, I usually just will email the investigator or sometimes the company directly just to say, do you have early access program? That's kind of the name for the program that's funded through this Act for ALS. So you can just ask if there is one, and I find that people are usually quite good at answering emails to say, we don't have our funding yet, check back in a couple months. But that's a great way to be able to access treatments if you don't qualify to be in a trial.
Be great if we can, Audrey, maybe get that on the ALS Network website as well. I don't know if it's accessible because that's would be much easier for patients to go that direction than try and email the PI of the trial.
Right, and I'm planning to share my slides, and it has the clinicaltrial.gov website, the ALS Network website. So hopefully that particular slide will be helpful for people to find out more resources later.
It's great, and just to cap it off with what you're both saying, soon in the coming weeks and maybe couple months, ALS Network will have our own clinical trial finder right on our website. That's going to be a new thing for us. So thank you so much. We'll be sure to add those important details. It's all important. We don't have any more questions, and I really can't thank you both enough for being here. You're such amazing collaborators for us and partners for so many years with the ALS Network. It's really valuable for us. Thank you both for being here. I think we have a few last slides to show. I just want to thank everybody for joining us tonight, just really being a part of our community. Big thanks to all of our sponsors for their support. And if you have other questions that weren't answered tonight, please do email us at askme@alsnetwork.org and we'll get those answered for you. As of January 1st this year, the California ALS Research Network Voluntary Tax Contribution Fund allows Californians filing their state income taxes to donate an amount of their choice to help fund ALS research. This was signed into law in September of 2023, and it will enable the establishment of a potentially stable funding source to support the work of our California ALS Research Network. Please find code 447 on your tax form to contribute. If you forget, just reach out to us and we'll remind you of that code. The ALS Network brings our community together in various ways throughout the year to create help, hope for families impacted by ALS today and for those who will be diagnosed in the future. These are really celebratory and meaningful gatherings that provide opportunities for connection and raising awareness and funds to benefit ALS Network's mission priorities. Visit us at events.alsnetwork.org to learn how you can join us. And as you know, philanthropy fuels everything we do. We're so grateful to generous donors who make gifts of all sizes throughout the year, including contributions through an estate plan. To learn more about how you can support valuable programs like this one tonight, visit us at give.alsnetwork.org and watch for the short survey on tonight's presentation that you'll receive to help us plan for more programs like this one. Thanks so much again.